Here it is, sir. So can I start now?
Ah,
Yeah. So good morning, everyone. Today I will be doing my drug expert on Deflazacort. So before I start, I just want to ask you guys if have you ever encountered this drug in the hospital, or do any of you have any information regarding it?
Something related to steroids or corticosteroids.
It's corticosteroid,
Yeah.
short acting.
Yeah.
Mm.
Good. And do you know like its indications?
Yeah, some Duchenne something is there, no? Autoimmune disorder. No, muscular dystrophy.
Muscular dystrophies and
Yeah,
Okay. Duchenne muscular dystrophy.
yeah.
Yeah, you are correct. That's the only indication that it has. So I'll be starting with this one first slide that contains the brand name, which is Implazine, Implaza, and the class it belongs to adrenal glucocorticoids or corticosteroids. And the available doses are 6 mg, 18 mg, 30 mg, and 36 mg. And the dosage form, it's available in two dosage forms, tablets and suspensions. So in India, the following brands are available along with the companies, producing companies, and the cost, as you can see here. So the first one is Orthocort 6 tab, 6 mg tab. It belongs to the company Macleod, and it costs around 46. And there is Nesta Quart Syrup by Cipla for 50 rupees. Temfly 6 mg tablet by Dr. Reddy's for 52. Deflaz 6 mg tablet by Intus, which cost around 57. Difstar 6 mg tablets by Centaur Labs for 80 rupees. And there is Dicotaz 30 mg tablets by Intus for 250 rupees. And we have Defcord suspension by Macleods for 57 rupees. So the definition of sorry, excuse this thing. It was supposed to be definition, but I didn't continue. So the definition for this one, Deflazacort is a glucocorticoid. It's an anti-inflammatory and immunosuppressive drug treating various diseases and is comparable to other anti-inflammatory steroids. Clinical studies have indicated that the average potency ratio of Deflazacort to prednisolone is 0.69 to 0.89, and 6 mg of Deflazacort is equivalent to 5 mg of prednisolone. It is indicated for various different conditions, such as indicated in other glucocorticoids, and has demonstrated equivalent efficacy to prednisolone and other oral steroids in rheumatoid arthritis, nephritic syndrome, SLE, transplantation, and chronic arthritis. So here I have included a slide with all the available steroids and its approximate equivalent dose. So as you can see, this is the Deflazacort, and with the equivalent doses of all the other steroids. So the indication is Duchenne muscular dystrophy. The dose in adults and in the pediatric is the same. So it's 0.9 mg per kg orally once daily, with or without food. We have to round up the dose to the nearest possible tablet size. And in case of suspensions, it's the same as well. We have to round up the dose to the nearest 10th of the ml. So regarding this drug, we have to make a notice about the because this drug causes immunosuppression. So we have to administer all the immunizations according to the immunization guidelines prior to initiation administer live attenuated or live vaccines at least 4 to 6 weeks prior to the initiation. So this rule is followed by should be followed by the adults and pediatrics as well, but with more concern or focus on the pediatrics. So I have included a slide here that explains about or just gives a brief explanation about Duchenne muscular dystrophy. It is a progressive form of muscular dystrophy that occurs primarily in males, though it is rare in cases may affect females. Uh, Duchenne muscular dystrophy causes progressive weakness and loss of skeletal and heart muscles. Early signs of DMD may include delayed ability to sit, stand, or walk, and difficulties learning to speak. Muscle weakness is usually noticeable by 3 or 4 years of age, by the age of 3 or 4, and begins in the hips, pelvic area, upper legs, and shoulders. DMD is caused by mutations in the DMD gene. The DMD gene codes for the protein dystrophin. Dystrophin is mainly made in the skeletal muscles and heart muscles. DMD is inherited in an X-linked recessive pattern. However, it may also occur in people who do not have a family history of DMD. While there is no known cure for DMD, there are treatments that can help control the symptoms. So regarding the mechanism of action of Deflazacort, it is a corticosteroid prodrug whose active metabolite, 21-disacetyl deflazacort, acts through the glucocorticoid receptor to exert anti-inflammatory and immunosuppressive effects. The precise mechanism by which deflazacort exerts its therapeutic effect in patients with DMD is still now unclear or unknown. Regarding the dosage adjustment for deflazacort, in renal impairment, there is no dosage adjustment required. In hepatic impairment, in mild or moderate, there is no dosage adjustment necessary. Concomitant use of moderate or strong CYP3A4 inhibitors, like with the following examples: clarithromycin, grapefruit, ketoconazole, and diltiazem, give 1/3 of the usual dose. And concomitant use of moderate or strong CYP3A4 inducers like phenobarbital, phenytoin, and rifampicin, we should avoid prescribing or administering this drug. Regarding its contraindications, the first one is the hypersensitivity to deflazacort or any component of the product. And most of the vaccines are contraindicated, as you can see. Adenovirus vaccine type 4 is contraindicated, but it should be, as I told you in the fourth slide, be given 3 to 4 weeks prior to the treatment starting with deflazacort. Adenovirus vaccine type 7, Bacillus of Clamete and Gurin vaccine, dengue tetravalent vaccine, influenza virus vaccine, measles vaccine, mumps virus vaccine, poliovirus vaccine, rotavirus vaccine, rubella virus vaccine, smallpox vaccine, typhoid vaccine, varicella vaccine, yellow fever vaccine, and zoster vaccine. When it comes to its pregnancy category, fatal risk cannot be ruled out, and breastfeeding infant risk cannot be ruled out as well. Adverse effects. The most common dermatological adverse effect is hirsutism, and the most common endocrine metabolic adverse effect as well is central obesity, so cushingoid faces, weight gain, increased appetite, increased frequency of urination, cough, nasopharyngitis, and upper respiratory tract infection. So as you can see, it has the same adverse effect profile as most of the steroids. Serious adverse effects: dermatological toxic epidermal necrosis, Cushing's syndrome, hyperglycemia, hypothalamic HPA adrenal axis dysfunction, and anaphylaxis. And also it might cause fracture of vertebral column due to reduced bone mineral density and infectious diseases. Coming to its pharmacokinetics, absorption, it achieves peak time after 1 hour fasting and 2 hour after a high-fat meal. Distribution, it's 40% protein bound. Metabolism, it's rapidly converted to active metabolite, 21 diacetyl deflazacort by esterases after oral administration. 22 diacetyl deflazacort is further metabolized by CYP3A4 to several inactive metabolites. Elimination predominantly urinary, 68% active metabolite accounts for 18 of this. Elimination is nearly complete by 24-hour post-dose. So as Rubaina said, it's a fast-acting glucocorticoid. As you can see, it achieves the peak plasma time within 1 hour. So the major interactions with this drug, it's mostly associated with the CYP3A4 liver enzyme, aceclofenac and deflazacort, concurrent use of glucocorticoid and non-steroidal anti-inflammatory drugs might result in increased risk of gastrointestinal ulcers or bleeding. Carbamazepine, deflazacort concurrent use might cause, because carbamazepine is an inducer, so it might result in decreased exposure to active metabolites of deflazacort. Ciprofloxacin is concurrent use of ciprofloxacin and fluoroquinolones and deflazacort may result in increased risk of tendon rupture. Calithromycin is an inhibitor, so it might increase exposure to active metabolite. Cephalosporin is an inhibitor. Cyclosporin, is an inhibitor, and it might increase the exposure to active metabolites. Fluconazole is also inhibitor, and it might result in increased exposure to active metabolites. And ibuprofen might cause gastrointestinal ulcers and bleeding. Modafinil is an inducer, so it might decrease exposure to active metabolite. Regarding the administration of this drug, it may be given with or without food. Tablets, regarding the tablets, administer whole or crushed and take immediately. Suspensions, only the oral dispenser provided with the product should be used. Suspensions, shake well before withdrawing dose. Slowly add 3 to 4 ounces of juice or milk. Administer immediately after mixing. Do not administer with grape juice. And suspensions as well, discard any unused product remaining after 1 month of first opening the bottle. When it comes to monitoring of this drug, what we should monitor is improvement in signs and symptoms of Duchenne muscular dystrophy, indicates efficacy. Blood glucose, regularly during treatment and for hyperglycemia after treatment withdrawal. Serum potassium levels, as this drug might cause hypokalemia. Adrenal insufficiency after the treatment withdrawal, to check whether the HPA axis is working properly. Development of infection, blood pressure and signs and symptoms of volume overload, bone mineral density testing in patients on long-term treatment. Patient education, advise patient to report symptoms of an infection, warn patient to avoid exposure to chickenpox or measles If history of previous infections is unclear and to report such exposure, tell patient to report rash. Side effects may include cushingoid appearance, weight gain, increased appetite, pola, pollakiuria, which means increased frequency of urination, hysterism, which is the abnormal hair growth, especially in females, central obesity, water retention, and hypertension. Instruct patient to report changes in mood or unusual changes in behavior. Counsel patients to report vision changes. Tell patients to avoid live attenuated or live vaccines during the therapy. Advise patients against sudden discontinuation due to potential for adrenal insufficiency. Again, this the last point uh, is a rule that should be followed along for the other corticosteroids as well. So these are a couple of points that I have picked up from some of the articles that I have gone through because I have seen it once being prescribed to an asthmatic patient. That patient was given in the beginning. That patient came with an exacerbation of asthma. So at the beginning, he was given 10 mg IV of hydrocortisone 3 times daily. Then in the PC ward, Dr. Girish changed the IV hydrocortisone to Deflazacort, and he had given him 6 mg 3 times daily in the beginning. So I have included the equivalency slide, so you can see how much dose it is equivalent to, like how much hydrocortisone is equivalent to Deflazacort. So here we have, like I said, I have picked up some points. Deflazacort versus other steroids. Deflazacort and prednisolone demonstrated similar efficacy in improving pulmonary function and clinical symptoms in treatment of children with moderate exacerbation of asthma. And Deflazacort has a similar impact on calcium metabolism than any smaller, impact on calcium metabolism than any other synthetic corticosteroid, and therefore shows a lower risk of growth rate retardation in children and of osteoporosis in adults and elderly patients. And another distinctive feature of Deflazacort is its smaller influence on carbohydrate metabolism than other glucocorticoids, as demonstrated in both studies conducted on animal models and clinical trials. So that means it's associated with a lower risk of hyperglycemia, and here it's associated with a lower risk of growth retardation. And Deflazacort risk of sodium retention and hypokalemia related to mineral corticoid activity of the drug is greatly reduced with Deflazacort in comparison with the older synthetic steroids. And because of its low liposolubility, only a small part of the Deflazacort biological active metabolite cross the blood-brain barrier. Thus, when compared to other or older corticosteroids, it is associated with a smaller on the HPA axis. In children receiving long-term steroid treatment after kidney transplantation, the substitution of methylprednisolone with Deflazacort over an average period of 15 months significantly increased growth hormone secretion and mean growth velocity. So as you can see here, when Deflazacort replaced methylprednisolone, there was a significant increase in growth hormone and mean growth velocity. Like I said, especially in the pediatrics, one of the ways that corticosteroids cause growth retardation is by the by stopping or reducing the growth hormone secretion, and at the same time by impacting the calcium metabolism, hence reducing growth as well. By this, I think I have reached the end of my this one, drug expert. Thank you so much. And if you have any questions, you guys are more than welcome.
Mohammed, okay, okay. Continue.
Yeah,
Yeah.
that's it. I mean, I forgot to include the thank you slide, like always. So, yeah, any questions?
Yeah, Mohammed. So you mean Deflazacort is same as potent as prednisolone?
Yes, it is as potent and as prednisolone, and 5 mg of prednisolone is equivalent to 6 mg of deflazacort. You can see
So
the
indication of Deflazacort over prednisolone, like what is your opinion? Can we suggest Deflazacort over prednisolone?
yeah, based on the articles that I have seen, uh, I will also include that along with this one when I post it in the group. Actually, it has been shown like a very promising side effect profile, because like last time when I saw Dr. Garish prescribing this one, I was like, Deflazacort, like I have no, that was like my first time that seeing a doctor prescribing that one. So when I went through the side effect or adverse effect profile, it was I mean, as you can see, as what I have explained in the last slide, it looks more promising, and yeah, you can go ahead and uh, I mean, suggest Deflazacort instead of prednisolone.
Yes,
So here, as
Okay.
you can
for
So
see,
why I
future
asked was because
indications
I remember
also.
reading this KD Tripathi that it is yes, it has got fewer side effects when compared to prednisolone, but that is in case of pediatric patients, no?
yes, in case of pediatric patients and also in geriatric patients, like like you have seen here, there was one point here. Just a minute. That last in the last slide. Um, so basically, it was associated with the less central obesity in adults. And also, here, another distinctive feature of deflazacort is smaller influence on carbohydrate metabolism than, just a minute, yeah, than other glucocorticoids, as demonstrated in both studies uh, conducted on animal models and clinical trials. So, I mean, even its effect on carbohydrate metabolism is less, basically. So it's associated with a lower incidence of hyperglycemias. And as I have said, like its incidence of central obesity is lower as well. I hope
Okay. Yeah, yeah,
that's
yeah,
clear.
yeah. Thank you, Mohammed.
Like its
Any yes,
efficacy in
yes, yes, Sharif.
comparison to prednisolone, only for
Mm-hmm.
few indications, it's like same effectiveness it's showing. Like you said, for SLE or transplantation, like
Yeah,
instead
yeah,
of metal prednisolone. But
yeah.
in nephritic syndrome, all other steroids can be used. But deflazacort has less effectiveness in nephritic syndrome.
In nephritic syndrome, right?
Yeah, nephritic syndrome. So only
Yeah,
for
yeah, yeah,
few indications we can say like it is effective
yeah, yeah. For
for
few indications,
transplantation, sarcoidosis, arthritis, and
yeah, yeah, yeah. Yeah, you are
mm,
correct. Plus,
mm,
there is one thing. In nephritic syndrome in pediatrics, I have seen that it has been used, and it
okay.
has shown a better side effect profile as well.
Mm.
I think I have said this point here somewhere. Yeah, in children receiving long-term steroid treatment for kidney transplantation. Oh, that's for transplantation.
For kidney
Okay.
transplantation. Mm.
Okay, okay. I thought it was for nephritic syndrome.
Mm.
But even like I have seen for nephrotic syndrome, it had the same like effect as methylprednisolone, and the side effect profile was not worse than this one, methyl this one, prednisolone. It had
Okay.
like almost the same.
Mm.
Yeah. So I'll be sending the article as well, or the article that I have referred. You can go through it. You will have a better understanding. Yeah, Sharat,
Come,
you had raised your hand, I think.
Ha, Mohammed. Like,
Yes,
how
yes.
much gap should be exactly? How much gap should be given before initiation of this Deflazacort after this immunization therapy? Like, is there any particular days or week? Week? How much days or
What?
how much? No, after immunization, you told you can't give the
Yes.
corticosteroids together, no? Like, exactly how
Yeah,
many days
yeah,
or how many weeks should be, many weeks of gap should be given?
yeah. I have mentioned it here. It's 3 to 4 weeks.
3 to 4 weeks.
I have highlighted. I have also uh, added here. Note: administer all immunization according
Okay,
to
4 to 6
immunization
weeks.
guidelines prior to the 4 to 6 weeks. Sorry, I said
Okay.
3 to 4 weeks. It was
Huh.
4 to 6 weeks.
And one more thing, Mohammed. Other than this DMD, all other
Mhm.
indications are off-label of this Deflazacort. Huh?
Yeah. The only indication. That's why I only included this one. The only
So this is
FD.
FDA approved for DMD.
Yes, only this one is the only FDA approved indication for Deflazacort. But the articles that I went through, they have they show that it's also indicated for so many other conditions. But based on the FDA, I just made this one based on the FDA indication.
Okay.
Because even if you see in the Medscape and all the websites, they clearly say that it's only indicated for DMD.
Yeah, one more thing, Abdullah, you have to give the tapering dose schedule also, no man, for this.
yes, sir. Even I was about to ask the same. Is this
Yeah, correct.
dose tapering same?
Yeah. You have to taper the dose. I have even added one point here in the patient education. Advise patient against sudden discontinuation due to potential for adrenal insufficiency. So this is like the dose tapering schedule I didn't include.
But it is same as other steroids.
Yeah, it's same as other steroids. It should not be stopped abruptly.
No. The tapering, like how the prednisolone
Tapering
will be
regimen, you're
tapered.
telling, no, you have
That,
to.
yeah.
That, mm.
What?
Tapering regimen, they are asking, like how it gonna taper, like you have for different drugs, different steroids, you are tapering,
Yeah,
no, like every alternate day or after 2 days, thrice in a week,
yeah.
something like that.
Yeah. That one I should have included, but I didn't include it. So, any other questions?
This is the drug that lacks mineralocorticoids, right?
What?
It's a doubt. Okay, like I'm not sure. Deflazacort lacks mineralocorticoids, right?
I didn't get you. Like, what do you mean? Like, what do you mean?
Like
It lacks?
and like not like I was asking about prednisolone. Like that. I don't know whether I'm right. I think Deflazacort lacks mineralocorticoids, like the effect on sodium, potassium, and all the fluid
When we
balance.
took that same
Yeah,
point in last time,
This belongs to glucocorticoids, no Deflazacort.
yeah,
it
yeah.
is the
But
glucocorticoid,
it has a very minimal effect on
mineralocorticoid.
mineralocorticoid effect. It's
Okay,
very
it
minimal.
has effect. Okay.
Yeah, but it's very
I
minor.
thought it lacks. That's what I asked.
Yeah,
Fine.
yeah. So, any other questions?
Yeah, in the last slide
Mm-hmm.
about the HPA axis you said, no?
Yeah.
So it's not because of that like crossing BBB, I think.
What?
The
Chronic
effect on
use of
HPA is due
That
to
is
the
type type
chronic use.
C adverse reaction to the steroids.
The
HPA
chronic.
axis suppression of
yeah,
that HPA axis.
suppression is
Mm-hmm.
mainly due to the levels, no? The corticosteroid levels in blood.
Yeah. You are correct.
the axis, not by crossing the BBB.
Can you repeat again your point, please, Rubaina?
It's not based on like whether it crosses BBB.
Which level
Yeah, so
decrease?
basically, if we what, sir?
What is the corticosteroid level decrease? What you are telling, Rubaina?
If it increases, chronic use causes
Chronic,
Sir,
HPA.
corticosteroid means even Deflazacort, it levels will affect the hypothalamic pituitary adrenal axis. It will give a negative feedback, so there will be suppression effect. It's not due to that like liposolubility or crossing the BBB.
But it does have this one, according to one paper that I have seen, it's crossing the crossing of this drug being reduced will help in like also reducing the suppression of HPA. So that's one point that I have seen. So I have included it. I don't know like the extent of like how much it might reduce the activity of HPA axis, but like it has some effect.
These glucocorticoids are only like they are involved in providing the negative feedback to the brain through like so that ACTH will be reduced.
Yeah.
Yes.
So these are glucocorticoids rather than this mineralocorticoids, androgens. These glucocorticoids are the one which is mainly involved in providing the negative feedback to the brain.
Okay, so that just means that they do have an effect. So reducing their penetration to the brain, or like what do you call it, crossing to the blood-brain barrier will definitely help in reducing the amount of suppression, right?
Okay.
Yeah. So any other questions?
Any other questions?
No, sir.
Yeah,
No, sir.
Govind had raised his hand.
Muhammad, just in case of this muscular spasm, it can be very painful, so it is anti-inflammatory also. So will it be used for this muscular spasm, other muscles, not on the skeleton or heart muscles? Because in like it will be used in DMD.
Well, basically in DMD, there will be muscle weakness, not muscle spasm.
That's why I asked now, is it can be used for muscle spasm also?
Well, I have no information regarding that. I have not seen it.
See, muscle spasm, more of muscle
any information
relaxants
regarding
are
that.
used. Muscle relaxants.
Yeah. I don't know what kind of relationship it
Like,
has with muscle spasms.
Okay. Any other thing?
Yes, sir. Priya has raised her hand.
Yeah, Mohammed, is this used in the replacement therapy like Addison's disease?
I have not seen like any indication for replacement
Off-label, at least, like, is there any off-label indication to be used in the Addison's?
No.
No, it's not there.
It's not there.
We usually prefer hydrocortisone for replacement.
Yeah, usually they will pick hydrocortisone.
Okay.
Those 2 points, nephrotic syndrome and Addison disease, are not included in the off-label indications.
Okay.
Any other questions, guys? Hello? You guys can hear me or what?
Any other questions?
Yeah.
Okay.
No, sir.
Guys, can you speak one by one, please? Because I don't know. Shala, did you say something?
No, nothing.
Okay. So shall I end the meeting or?
Okay. We'll stop here. Okay.
What,
Thank
sir?
you. Yeah, we'll stop here.
Okay, thank you. Yeah, okay, thank you.